Ever feel like your body's playing this high-stakes game of Jenga?
Hmm.
Well, get ready to explore that feeling in today's deep dive,
Yeah.
because we're tackling coagulopathies in the ICU, where the stakes are life and death, and the tower is your blood's ability to clot or
Right.
not.
And you really don't want that Jenga tower toppling in either direction.
Right.
We're working with some pretty intense research here, excerpts from coagulopathies in intensive care medicine, balancing act between thrombosis and bleeding.
Mm-hmm.
Get ready for a crash course in why this balance is so crucial, especially for those in critical care.
Okay, so before we get into all the ways things can go wrong, let's break down the basics. What exactly is hemostasis, and why is it so important?
Okay, so imagine this. You get a tiny cut, nothing major. Hemostasis is your body's way of saying, nope, not today,
Mm-hmm.
and dispatching a team of cells and clotting factors to patch things up, preventing you from bleeding out.
Yeah.
It's this constant dance between stopping bleeding when needed, but also making sure your blood doesn't clot unnecessarily.
So it's like a finely tuned internal system that keeps everything flowing smoothly.
Exactly.
But, as I'm guessing from the title of our research here, this balance can get disrupted, leading to what's called a coagulopathy, right?
Precisely. And this is where it gets really interesting and complex
Mhm.
for doctors in the ICU.
Yeah.
A coagulopathy isn't just about excessive bleeding, as some might assume. It's about this delicate equilibrium being thrown off kilter,
Mm.
either towards too much clotting or not enough.
So we're talking about two sides of the same coin.
Ex-
On one hand, there's thrombosis,
Right.
which is basically the formation of dangerous blood clots.
Yeah.
We're talking about serious risks like pulmonary embolism, where a clot travels to the lungs,
Right.
or DVT, a clot that typically forms in the legs.
And on the flip side, you have hemorrhage, uncontrolled bleeding.
Okay.
Just like thrombosis, if not caught and treated properly, hemorrhage can quickly escalate into a life-threatening situation.
And this is where it gets really interesting and a little scary, right?
Yeah,
These conditions, thrombosis and hemorrhage, can actually coexist.
absolutely.
A patient in the ICU could be battling both clotting and debleeding problems at the same time.
At the same time.
Talk about a medical curveball.
Absolutely. It's like trying to solve a Rubik's Cube while riding a unicycle. A real balancing act for intensivists. They need to figure out why this balance is off in the first place, and then tailor treatment very carefully, because what works for thrombosis might exacerbate hemorrhage, and vice versa. It's a high-stakes puzzle.
And like any good medical mystery, there are clues to help us understand what tips the scales towards either thrombosis or hemorrhage. Let's talk risk factors. What are some of the things that might make someone more vulnerable to these coagulopathies?
Well, some culprits are lurking in plain sight.
Okay.
Age, obesity, cancer.
Right.
These can all increase the risk of dangerous clots.
Okay, so those are like the usual suspects, things many people might already associate with blood clots. But then you factor in the unique environment of the ICU. Someone might be immobile for days on end, which can't be good for healthy blood flow.
Exactly. And then there's the curveball that is COVID-19.
Oh, yeah.
This virus really throws a wrench into the coagulation system, increasing the risk of both clotting and bleeding. In the ICU, they use scoring systems, like the ICU VTE score, to assess a patient's risk of developing clots based on these various factors.
Right, these scoring systems are like having a specialized medical checklist to make sure nothing is overlooked. But what about the flip side? What tips the scales towards excessive bleeding or hemorrhage?
Think about the organs that play a critical role in clotting. Liver disease is a major one.
Okay.
The liver is like a factory for producing clotting factors, those essential proteins that help stop bleeding.
Yeah.
So if the liver isn't functioning properly, you're at a much higher risk of uncontrolled bleeding.
That makes perfect sense. And our research also mentions kidney disease. Does that also impact clotting factor production?
It's a bit different with kidney disease. Kidney failure can actually disrupt the function of platelets,
Okay.
those tiny cells that rush to the scene of an injury to form a plug and stop bleeding. It's like having faulty bricks. Even if you have enough mortar, clotting factors, the wall won't hold if the bricks themselves are weak.
So it's all interconnected. Organs, cells, these clotting factors. It's a delicate system. And just like with thrombosis risk, doctors use scoring systems like the Hemmer-Coagulopathy score to assess the likelihood of bleeding based on various risk factors. But what I find fascinating and a bit alarming is that our research emphasizes how these risk factors can often interact, creating a domino effect that makes the situation even more complex.
It's like a medical puzzle where the pieces are constantly shifting.
Yeah.
Let's look at some specific examples to illustrate this. Take disseminated intravascular coagulation, or DIC.
Okay.
This one is a real game changer in the ICU.
DIC, it sounds intense. What exactly is going on there?
Imagine your body's clotting system going into overdrive,
Okay.
creating tiny clots all over the body. It's like the emergency brake is stuck on.
Oh, wow.
This uses up clotting factors and platelets faster than the body can replenish them, leading to a double whammy. Clotting problems in some areas and uncontrolled bleeding in others. DIC is often triggered by sepsis, a life-threatening response to infection.
And sepsis is already a serious condition on its own. Our research mentions a chilling statistic. A CAIOC score, which is used to diagnose sepsis-induced coagulopathy, of 4 correlates with a mortality rate over 20%. That really highlights the seriousness of DIC.
It does. Early recognition and treatment are absolutely critical.
Yeah.
But DIC isn't the only type of coagulopathy intensivists encounter. Trauma, for instance, can also throw the system off balance.
Trauma-induced coagulopathy. That makes sense. Massive blood loss is a hallmark of severe trauma, and our bodies are wired to stop bleeding as quickly as possible.
Right. After a severe injury, the body kicks into overdrive to stop the bleeding. But this intense response can deplete clotting factors and disrupt the normal coagulation cascade. It's like slamming on the brakes so hard that the car spins out of control.
And we've already discussed how vital the liver is to coagulation. Our research really emphasizes how its role in producing those clotting factors makes liver disease a significant risk factor for coagulopathies, particularly those involving bleeding.
And let's not forget about kidney disease, which, as we discussed, can lead to platelet dysfunction, making it harder to form those initial plugs to stop bleeding.
Right.
Even COVID-19, with its multifaceted attack on the body, can disrupt this delicate balance,
Yeah.
increasing the risk of both thrombosis and hemorrhage, which makes treatment extremely challenging.
It's amazing how interconnected all these systems are, but it's not just illnesses that can disrupt this balance, right? Even the life-saving medical technology used in the ICU can come with risks. Our research mentions ECMO, for instance.
That's right. Even ECMO, a type of life support that essentially acts as an external heart and lungs, can interfere with coagulation.
Wow.
While it's a life-saving intervention, it can increase the risk of both clotting and bleeding complications.
It's a trade-off that highlights the complexities of critical care. And speaking of complex, our research also mentions acute burn-induced coagulopathy, or AB.
That's right, AB. Severe burns, much like trauma, trigger a massive inflammatory response that can disrupt coagulation, adding another layer of complexity for intensivists to manage.
It seems like just about everything in the ICU, from pre-existing conditions to the treatments themselves, can impact this delicate balance. So we've explored this intricate web of risk factors that can tip the scales towards either thrombosis or hemorrhage.
Right.
But how do doctors in the ICU actually unravel this medical mystery? What tools do they use to figure out what's going on with a patient's blood clotting?
It often starts with a race against time,
Okay.
quickly spotting the telltale signs of potential coagulopathy,
Right.
any unexpected bleeding, or conversely signs of clotting.
Right.
Send up red flags.
Yeah.
As our research highlights, the faster they diagnose the problem, the faster they can intervene and hopefully prevent a dangerous cascade of complications.
Early detection is key.
Yes.
So how do they piece together this puzzle? I'm imagining a battery of high-tech tests, but let's start with the basics.
Sure.
Are we talking standard blood tests as a first line of defense?
Absolutely. Tests like prothrombin time, PT, and activated partial thromboplastin time, APTT, are often the first clues.
Okay.
They give a general sense of how long it takes for blood to clot, which can hint at potential problems.
They're like a quick snapshot of the system.
Exactly.
But our research suggests these tests don't tell the whole story.
That's right. They're a bit like looking at a single frame from a movie.
Okay.
You might get a glimpse of the action, but you're missing the context and the nuances. For a more complete picture, doctors turn to more sophisticated tools.
Our research mentions something called viscoelastic testing.
Yes.
It sounds pretty high-tech. Can you walk us through what that is and how it's different from those standard clotting tests?
Think of viscoelastic testing as watching the entire movie of coagulation unfold in real time.
Okay.
Instead of just measuring how long it takes for clotting to begin,
Right.
this technology analyzes how a clot forms, how strong it is, and even how well it breaks down afterward.
Yeah.
All crucial aspects of healthy coagulation.
So it's like having a front row seat to the clotting process, seeing the entire choreography, not just a single step.
Exactly.
How has this technology changed the way doctors approach treatment?
It's been a game changer for personalized medicine.
Okay.
By seeing the whole picture,
Right.
Doctors can pinpoint the exact point in the coagulation cascade that's going awry.
Mm-hmm.
This allows them to make more informed decisions about which treatment will be most effective for that specific patient.
Yeah.
There's even evidence that viscoelastic testing can help reduce unnecessary blood transfusions,
Oh, wow.
minimizing potential risks and ensuring patients get the most targeted treatment possible.
That's a win-win for sure. And it sounds like there's even more advanced technology at their fingertips.
Right.
Our research mentions things like platelet aggregometry and real-time anti-Zem monitoring. Are these becoming standard practice in the ICU?
They are gaining traction,
Okay.
especially as we learn more about the complexities of coagulation. Platelet aggregometry zooms in on how well platelets,
Yeah.
those first responders to an injury,
All right.
are actually functioning. Are they sticking together properly to form that initial plug?
Yeah.
Are they doing your job effectively?
It's like quality control for your platelets.
Exactly.
Yeah.
And then there's anti-exam monitoring,
Mm.
which is especially useful for patients on certain blood thinners.
Right.
Doctors can now monitor the levels of these medications in real time,
Yeah.
ensuring the dosage is just right,
Yeah.
preventing clots without increasing the risk of bleeding.
It's amazing how far medical technology has come. But knowing what's wrong is only half the battle, right? Once a coagulopathy is diagnosed, what are the treatment options and how do doctors decide which path to take?
The key takeaway from our research is that there's no one-size-fits-all approach.
Right.
Treatment is like a tailored suit. It
Yeah.
has to fit the specific coagulopathy,
Mm-hmm.
the underlying cause, and of course, the patient's overall condition.
So if the problem is thrombosis, are we talking about medications to prevent blood clots, while hemorrhage might require something completely different?
Precisely. For thrombosis, anticoagulants
Yeah.
or blood thinners
Yeah.
are often the go-to.
Okay.
These medications help prevent clots from forming or getting bigger.
Right.
Hemorrhage, on the other hand,
Yeah.
often requires a different strategy. It might involve replenishing depleted clotting factors with something called clotting factor concentrates.
So it's about restoring that delicate balance, either thinning the blood or giving it a boost, depending on the problem.
Exactly. And there are medications called antifibrinolytics
Okay.
that can help prevent clots from breaking down too quickly. Another tool in the arsenal, depending on the situation. And of course, if platelet counts are dangerously low, platelet transfusions might be necessary.
It's a complex decision-making process.
Mm.
Our research mentions some debate surrounding the use of fresh frozen plasma, or
Yeah.
FFP,
Correct.
as a treatment option. What's that all about?
FFP is a blood product that contains all the clotting factors.
No.
So it seems like a logical solution for certain coagulopathies,
Right.
especially those involving bleeding. However,
Yeah.
like any medical intervention,
Right.
comes with potential risks.
What kind of risks are we talking about?
Well, as with any blood transfusion, there's
Yeah.
always a risk of infection. But with FFP,
Yeah.
there's also the risk of volume overload, which means giving the body more fluid than it can handle. This can be especially dangerous for patients with heart or kidney problems.
So it's a balancing act, weighing the potential benefits against the potential risks.
Exactly. And that's why the debate surrounding FFP is so important. Researchers are working to define more specific guidelines for its use when it's truly necessary, and when other treatment options might be safer and more effective.
Right.
Interestingly, there's even research exploring other potential benefits of FFP beyond clotting.
Really? Like what?
Some studies suggest that FFP might have protective effects on blood vessels and could potentially help reduce inflammation.
Interesting.
But this research is still in its early stages.
It seems like the world of coagulopathies is full of these intricate puzzles, with researchers constantly searching for new pieces. So if we had to distill everything we've learned today into a single take-home message, what would it be?
I think the most important takeaway is that while coagulopathies are serious and complex,
Right.
they are not insurmountable. Equipped with advanced diagnostic tools, a deep understanding of the mechanisms involved, and a commitment to personalized medicine,
Right.
doctors are making strides in the fight against these conditions.
Knowledge is power, as they say.
Yeah.
And hopefully, by diving deep into this topic today, we've equipped you with a better understanding of how this delicate balancing act of coagulation works, both when it's functioning smoothly and when it goes awry.
It's a topic that's often overlooked,
Yeah.
but as we've seen today,
Right.
it's incredibly important, especially in the high-stakes environment of the ICU.
Absolutely. So until our next deep dive, stay curious, keep asking questions, and remember, the more you know, the better equipped you are to navigate the complexities of your own health.